Welcome to ZOOMERTIMES TV. And here's your host, Anita Finley.
Everyone, this is a very important interview. You know, we have authors, we have lots of people, but I have now a combination lawyer and a interventional cardiologist. So we have like a double deal here. Dr. Waqar Khan is calling in from Houston, and we've had him on years ago. If some of you remember, he wrote a book that was called Heart Smart. Does he be Heart Smart? And it was a great, it's little, small book, but it was perfect. And I was always so impressed with it. So we asked him to come back on now. So hello, Dr. Khan. We're glad that you got finished with your operations today and you could join us.
Thank you, Anita. It's a pleasure to be here.
Thank you. So let's get into the interventional cardiology because it seems like like stents are it's the new technology, the old technology. Why don't you talk a little bit about what you think about it, what you do, and where it's going?
Sure.
I'm just going to be quiet.
Very happy to do so. I think every person, um, every adult in this country has got some family member or friend that either has a stent or has had some type of bypass surgery. So, interventional cardiology is a field where we perform interventions or operations that do not involve opening up the chest. That department is cardiovascular surgery. That separates us from cardiovascular surgery. We do all our procedures by entering a vessel or an artery, as we call it, either through the hand or through the groin. And using those techniques, we're able to go inside those arteries that have blockages that lead to heart attacks and chest pain, etc. And we open those up with stents, which are little metal tubes. They're metal meshes. We insert them in those arteries, providing a scaffolding so these arteries won't collapse and therefore establish blood flow to the muscle of the heart that keeps it beating. That's what it's supposed to be doing. And that's in a nutshell. Now, stents came out about some 30 years ago or so. I would say almost 40 years, 30 to 40 years. And we have improved on the quality of stents, the type of stents in those last 3 or 4 decades. Now, the stents that we use are coated with drugs so they don't close, they stay open. They're just as good as bypass surgery. And therefore, almost 90% of patients who have blockages end up with stents versus 10% who got bypasses, which was reversed about 40 years ago.
Okay, well that's good. Now, do you have a stent there in your office? I do have
When
it
you
there.
mentioned to me, I was looking for a stent, and I will show
I know,
you.
I saw you looking.
I was looking, and I am. Let me see. Let me see if I can find some a model. Uh, so I do. I used to have. So this is a model, which let me see. So it doesn't show a stent, but it shows a stent on the side, which is. Do you see it on the side?
Yes.
This is the stent right there.
Hmm.
It's such a transparent model. It's a glass model. It's kind of
I
hard
see.
to see, but
Uh-huh.
here in this model, I'll show you. Hopefully, we can see some. We may not see the stent here, but you see the arteries, and you do see a stent actually. I do have a stent here. Let me point out to. Do you see this one?
Yeah,
That's a stent.
I see.
The stent is like a little metal mesh, and this is a person's heart, and these are arteries. You see those here? Those are
Yes.
arteries. And in this model, I can rotate it so we can go to the back of the heart also, and we can see those vessels at the back. And these, if there are blockages here, that kind of stent we saw that is placed in these vessels also. It's delivered through the groin or the arm. We go inside these vessels and insert the stents.
Okay, so my question is, in order to do that, you have to actually have, I guess, a video camera to know where you're going, correct? That's robotic, isn't it all robotic then?
Absolutely. So, to answer the first question, we do have a camera that's recording everything we're doing. So, the camera in old days, it used to be just movie cameras that movies are made out of 35 millimeter. Now, these are all digital pictures, just like the one you're interviewing me on. So, very similar. And So we do have that. Now, robotics, second question. We are using robotics. It's not very common yet in interventional cardiology. It's more common in surgery. But we are using robotic arms that we can manipulate just like a video game from a separate room. And one person inserts it into the body, the other person controls it, the robotic arm through a computer. Those are relatively in early stages, not being done everywhere. I think there are some technical issues of doing it through robotics at this point. Surgery is somewhat easier, but most of these tests are done in what we call as a cardiac catheterization laboratory, which is kind of an operating room. It is a very sterile room. There are 2 or 3 helpers that are scrubbed in, sterile. They're wearing sterile clothes, sterile gowns. The doctor is wearing sterile gowns. The procedure itself can take anywhere from 30 minutes to up to an hour and a half, depending on complexity and how many vessels are being done. But it's a very safe procedure. I would say it is more than 90% safe, so quite safe. Patients go home majority of the time the same day. I would say 90% of the time they go home the same day. It's a same day procedure. In some cases, we may keep the patient overnight and patient gets discharged home the following day.
So Dr. Khan, are you already seeing what you need to do before you get in there? I have to assume you are.
So before we get in, yes, very good question, actually. So before we get in there, we do some tests to identify those patients that we suspect have blockages. Those tests can be a nuclear stress test. Sometimes it could be a plain stress test. Sometimes it could be a procedure called PET scan that can also show us. Sometimes we don't do a procedure. We just go by the symptom. The symptoms are so classical that we know based on the patient's risk factors and their symptoms that they clearly have a blockage, and we go straight to a heart cath. When we do this heart cath procedure, we take the pictures first, just like you asked me. So we know that this patient has 2 blockages or 3, and most of the doctors, majority of the time, it's the same doctor that does stents. If that's the case, that doctor will stent. At least if there are more than 1 vessels, he'll do at least 1 or 2 at the same time. Now, there are some doctors who are called invasive cardiologists. They're not interventional. They might do a cath, then they'll refer that case to another doctor who's interventional. He'll do a stent on a separate day.
I see. Well, so the one thing that strikes me is that when we used to have people with open heart surgery, it was a lot of recuperation, a lot of time. And everyone I've known who's had a stent seems like they're home the next day or so.
That is correct. That is correct. So yeah, I mean, this procedure has become so exceptionally simpler, and in good hands. This procedure does not require to stay, and most patients are able to go home, like I said, the same day. So it is a lot easier now.
Well, let's really go through now. You, of course, you're an interventional cardiologist. You don't only do stents. What else do you do?
So besides stents, I mean, stents is part of what I do, but we also are performing various tests to identify blockages not only in the heart but also in the legs, in the carotid arteries, which are right here that go up to the brain. We're also looking or taking care of patients who have heart failure, meaning the heart muscle is weak, that need to be treated. We are taking care of patients who have rhythm disorders and their heartbeat is either fast or is irregular. So it's a whole gamut of things. And we're also taking care of patients who have leaky valves or tight valves. They need to be evaluated and treated. So we have valves, we have rhythm problems, blockages, and you just mentioned kidney stent. So we look at blockages in other places too. So interventional cardiologists, not all of them, but the majority of them are not only working on hearts, but also on arteries in the legs, the kidneys, and the carotids as well.
It is, I think of all the technology that I've been hearing, the stent technology, and who invented that? Was there a particular person? Or
Yes, yes. So the first, that's
was his name Stint? No, I'm kidding.
No, his name was not Stint. The first person who did angioplasty, which is the precursor of stents, opening the balloon, was done by this fellow. He was a German surgeon by the name of Dr. Grunzig. So Dr. Grunzig performed this first procedure in the early 80s, late 70s. He happened to be, I think, in Emory University, but he did the first procedure back in Germany, even though he was trained in Emory. After that, stents came in a different doctors made their contributions. Dr. Palmas Schatz was a gentleman who is now in San Antonio. He was involved with the early stents. Dr. Gary Rubin, who used to be in Alabama at the time. So different people involved, but the procedure was started by Dr. Grudzik.
Okay, so, and that was, you said, a long time ago. How long?
I think it was, if I'm not mistaken, 78 or 79. And then,
Wow, long
yeah.
time ago.
So that was the first time. And then it became more commercially used after 5-6 years. Like, angioplasty was used in the early 80s, but the stents, the first stent that was put in, or the stent that became FDA approved, were more or less in 94, 95, or somewhere in the mid 90s.
So Dr. Khan, of course, you were trained as I guess, I don't know, were you trained as a cardiologist or as an interventional cardiology from the very beginning?
That's an excellent question. To be trained as an interventional cardiologist, the doctor has to first go through medical school, of course. And after that, we do a 3-year residency in internal medicine, general background in all aspects of medicine. After the 3-year internal medicine residency, we go through a 3-year cardiology fellowship. That's called general cardiology. And after those 6 years, we then go for training 1 to 2 years in interventional cardiology. So the total number of years after med school is about 7 to 8. Then you are trained to do it. So it takes a long time. We are in our 30s by the time we are done with all this.
But it's exciting because thinking about it, you as a physician want to have great outcomes, and you also want to do preventive medicine, which you're doing, because if you didn't have this, probably people would have strokes or they would have heart attacks. And so now, when do they wind up coming to you? Does the primary care person send them to you, or does a cardiologist? First, the primary care sends them, the cardiologist sends them to you. What's the system?
Well, mostly, you're correct. Mostly we get patients who come through PCPs, the primary care physicians. They present to them with either multiple risk factors. Those risk factors are diabetes, high blood pressure, family history of heart disease, history of high cholesterol or smoking. So when the family physicians identify those risk factors and their age, they'll refer them to us for screening. Most of the other times, the patient goes to the family physician and complains of shortness of breath or chest pain. And then they get referred to us for evaluation of this breathing difficulty or chest pain, which can be a sign of heart disease. That's the sort of typical scenario. Or an abnormal EKG sometimes.
Right. How old is the oldest person you've ever done a stent on?
So the oldest person I've done a stent on probably is about 100 years old.
Really? I didn't expect that.
Yeah, no, that's not typical. That's not typical, but you asked me the oldest person. If you ask me as a group, the oldest people that I've done as a group are under 95. So that'll be the oldest group. 90 to 95 is my oldest group. We tried to only do those patients who are fairly active. They have active lifestyle. There are some 90-year-olds who are fairly active, particularly in Florida. Yes. I was in Florida for a year and a half. That's where I worked on a lot of Floridians who are 90-year-olds. But in Texas, I noticed our 90-year-olds are not that many as Florida, because we are not a retirement community, I guess, as large as Florida has. And they're not as active. So it does depend on a lot of activity. Now, the 80-year-olds, we do a lot. The octogenarians, we do a lot of those.
Right.
Octogenarians, we do a lot.
So you now are working at a hospital in Houston. And what is that? Which one is that?
So I'm working for one of the HCA facilities in Houston called HCA Healthcare Center in Tomball. It's a northern suburb of Houston.
Right. And so do you like living in Houston?
Yes, I've been in Houston for a long time. I did actually took a hiatus, and I was in Florida, South Florida, in Boca Raton for about a year and a half, worked out in Delray Beach area,
right,
and also in West Palm. And I was there for a year and a half, but my family is sort of my kids who are born and raised in Texas. We had family in Florida, but my kids sort of, just wanted us back. So we are back home, so to speak. And
I see.
Our kids are obviously growing up and leaving, but they brought us back.
That's true. Well, I actually lived in Huntsville, Texas for 3 years.
Not very far from us, very close.
No, I know where it is because we used to drive there to get away from Huntsville.
So I'm in Tomball, as you know. Tomball is fairly close to 45. I live in the Woodlands, which is very close to
I
Huntsville.
know the Woodlands. It's a new town, and my husband was a
Yes,
new town developer, and he knew the man. We went there when they first were being
Mitchell.
invented.
Mitchell was the
So yeah,
gentleman who, yes, yes, exactly.
right. Yeah, it's beautiful. That's great. But let's now get back into cardiology. So let's go into you started talking about blood pressure. Let's just talk about blood pressure.
Sure.
Um, we have all these different, some people think you should have much lower than other, and some doctors say no, it's okay. So let's put your cardiology hat on. If is it in your genes that maybe you'll never get really low, and should you be taking a lot of medication to make that happen? Or just talk about a patient coming in that has maybe 140 over 70 or something. Is that
Yeah,
something
so,
you have to worry about?
yes. So, first of all, the general guidelines for blood pressure, uh, the traditional guidelines always have been 140/90. So 140 is called the systolic or the upper number, and diastolic is the lower number. 140/90 is classic or typical. Now, last year, the gods of cardiology and high blood pressure decided to change those numbers based on the data, and they made it a little lower. So they changed it to 130/80. So they said if someone has a pressure that is above 130/80, maybe they are pre-hypertensive. They are going to get high blood pressure, and therefore they should be watched closely, diet changes, exercise, etc., and everything needs to be instituted so they don't get blood pressure. So, from a patient standpoint, from your audience, I would say keep in mind the number 140 and 90. Anything above that definitely requires a trip to your doctor for sure. And if you're in your 130s and above 80s, at least let your primary care physician know so he can start advising you to avoid salt and exercise on a regular basis and watch your weight and diabetes, etc. So 140 numbers number one thing. The second thing I'll mention is that for those people who have high blood pressure and diabetes, they are at a very high risk of developing heart disease and stroke. So for those people, we are more strict. For patients who have diabetes, we want their pressure not just lower than 140. We want to be even go lower if we can, below 130. And the bottom number, we want it to be lower than 85 for sure, possibly under 80. So there is some strictness of blood pressure control required for diabetics. But outside of diabetes, 140/90 is a good number to remember.
What is the problem with the diabetic? Why does that worrisome?
Diabetes itself is a huge risk. So diabetes is a precursor of different plaque which forms inside arteries and leads to blockages. When you combine that, studies at the epidemiology or epidemiological studies shown that patients who have diabetes and hypertension, it just flares up their plaque a lot more, instigates more plaque formation. And I think we as doctors don't even know the exact mechanism, but we do know that this combination is leads to more blockages.
I see. So yeah, the history shows you that. And how about when you talk about, you didn't talk about it, but stress. Sometimes you can't really control stress. Let's say you can control all the other things. What do? You just have to go into meditation. What is it that's so important with stress?
So let me tell you, there's one other thing you can't control, by the way, and then I'll talk about stress, and that's your family history. You can't control your family history genetics.
Right.
So stress can still be controlled. Obviously, it will take more heroic measures in some cases to control it, but it is tough. And obviously we can talk as much as I want, but I'm not a psychologist or I'm not a really a psychiatrist. But I do mention stress. I talk about it. Unfortunately, I can't tell people what to take, but sometimes it may require a visit with not necessarily a shrink, but maybe a psychologist of some discussion of how they can lower the stress by sometime by talking, but sometimes may require medication. But I tell people to consider yoga. There are a lot of studies of deep breathing and yoga exercises of reducing stress. So as far as I am concerned, I talk about lowering stress and also about exercising because that does take your mind off if you're able to regularly exercise and considering deep breathing yoga type exercises, deep inhalation with longer exhales, and yoga. I think that I can do that part. Anything more than that, they will require a trip. If there's something they can't control, they might need some counseling.
On a personal note, you're under a lot of stress. Do you do yoga?
I try to do my exercise. What I do is I'll be honest with you. I did do yoga. I have not done it, and I've stopped a few years ago. But I learned those breathing exercises. They're helpful. But I made it a point to at least go to the gym and
Uh,
work out 3 to 4 times a week. So I try to
oh,
do that. Yes.
okay, that's great. My guest is Dr. Waqar Khan, and he's calling in from Houston, and he wrote a book that I suggest you get. It's Be Heart Smart, and I'm trying to remember what the other part of it says. It's Be Heart Smart, and what's the words with it?
The other word is understand, treat, and prevent coronary heart disease.
Yes, it's a lovely, it's a small book, but it's well written. And I suggested you get it. You know, everything you can do to help yourself. Dr. Khan has been very generous with his time and telling us a lot of these things. The one thing that's very important is that you do have, you do go to the doctor. You please go to the doctor. With COVID, a lot of people decided not to do that, but you need to do it, and you have to be very aware of all the things that he talked about: exercise, not to smoke, and to, if you have family history, and try not to have stress. Make sure you eat properly. Now, a lot of us are on plant diets. We've gotten rid of a lot of meat and all, and a lot of us try to eat a lot of fish. Isn't that the best way to go, the diet?
I think diet is excellent. Plant-based diet is really popular. Dr. Esselstyn has been writing some books I know on plant-based diet. Uh, there are all kinds of plant-based diets, but plant-based diet is great. I think whatever diet you want to follow, you want to eat healthy food. You want to avoid bad fats, those trans fats, and saturated fats. And you want to go with monounsaturated, polyunsaturated fats if you do. Try to add more vegetables and fruits and green leafy vegetables to your diet. And if you can get protein from the plant-based diet, that's perfect because it can provide you the protein you need. Otherwise, eat in moderation. And if you're a heart patient, then you need to be more strict. If you're not, try to eat in moderation. Try to avoid a lot of meats in your diet on a weekly basis. Maybe reduce it to once or twice. Maybe add fish. Oily fish is good. Salmon is great. Other fish is fine too. So I think if we start in moderation, that would be a good start. And add exercise to your good dietary habits. That would be
Right.
great.
You just, and now we see people are living to be 90, 100 years old, and it's more common. I've just, when the New York Times, it seems like a lot of famous people, they died at 95, 98. And so we don't want to, it's one thing though to live long, but we want to live healthy. We want to be able to walk, we want to be able to enjoy our life. And so when people come to you though, they can walk, not walk out, but eventually walk, maybe take
Yeah,
out, go to take out after you take care of them.
yeah.
And you think they'll ever need a stent again?
Well, I think that people who get stent, they may get blocked to other places of the body too. Is that what your question was? If somebody gets a stent,
Yes. Did
yes,
they need it?
sometimes they might need, and the stent is not needed because it's the first stent that's not working. They may get blockages at other places because the arteries are like twigs of trees. They're long, so there could be other areas too. So that's why watching your diet and regular exercise is very important because you don't want to get more blockages.
And in order to find the blockages you have, you did that very quickly. There are certain, you go to the diagnostic places, and what
Yes.
is it that can see that?
So what you follow up with your cardiologist, and your cardiologist will, on a routine basis, either every year, depending on your symptoms, or every other year, would do a nuclear stress test or a PET scan to look at flow through your heart. And if he finds out that the flow is obstructed, then the next step will be to do a heart cath and possibly a stent. But there will be routine tests that will be done on you on a routine basis to make sure that the stents that were done earlier are fine and there are no new blockages that are developed over the time.
If someone wants to get in touch with you, how would they do that? Do you have a website, or what would they do?
I think that the book website is good. I also have a website called LoneStarCardiology.com, Lone Star being Texas. But we, but we also have a book website called HeartHealthBooks.com. So www.hearthealthbooks.com.
Oh, okay. That's great, because you never know when people want more information. So do you find that people fly to you from other places? I mean, are you seeing out of state patients?
We've seen a few out-of-state patients, yes.
But what you're saying, I believe, is anyone who's really been educated into the interventional cardiology can
Can
pretty
take,
much
absolutely,
handle,
absolutely.
right?
I think if they're, yeah, of course. I mean, it's cumbersome. It's difficult for heart patients to travel out of state, but anyone who is board certified in interventional cardiology, meaning they have gone through proper training and then taken an exam, is qualified to take care of patients who are suspected of having a blockage in their heart. Yes.
And all hospitals are prepared for it. And I think there are even some clinics, if I'm not mistaken, some interventional cardiologists that can do this in their outpatient clinic.
There are a few outpatient clinics where it can be done. There are a few. I would still advise that a hospital would be a better location, just
Yeah, in case
because
some,
these procedures can have complications. They're rare, and the presence of a surgeon or a hospital OR is a good idea. But most hospitals, like you said, are able to do that. There are some hospitals that they're not capable of doing interventional, but there are very few. I think I would say 80% of the hospitals are qualified now or capable, have the services to take care of patients with blockages using interventional procedures.
right. And just on another note, how has COVID how are you handling that in Houston? How's it going there?
We did not get as much COVID as the Northeast, but we had a fairly large share of COVID about 6 months or ago or so. But we are down. In fact, I just saw news a couple of days ago, and I don't know the status is today or yesterday, but 2 days ago we had no deaths from COVID in Harris County, which is Greater Houston and Houston.
Wow.
So I think COVID is very, very now, thankfully, scarce. We don't see a lot of COVID, and the numbers have gone down a lot. Things are getting better, and out of my own practice, I think about 80% of my patients have been vaccinated, so a fairly large number.
Yeah. Have you?
Oh yes, I got
Oh,
vaccinated in
yes.
December, so I got
Right.
vaccinated when it first came out. But yes, my family's
I
all
did.
vaccinated as
I
well.
did also. I did it. The one thing that and you talked about this with the interventional operations. Even I have advised people, maybe not so now, but when it first happened, go and have this done at a medical facility. I didn't want to go to the pharmacy, so I went to a hospital and had it done there. But looks like
Yes.
we're out of time, because Dan is now hunting me down to say,
All
okay,
right.
we're about to go. So Dan, in the last minute or so, what do we have? 2 minutes?
Yes, we
So
have
Dan's
we have
had some
about 5 minutes.
stents.
Yes.
Dan's had some stents. I know he
Oh,
probably want to talk to you about that.
Yeah.
looks good.
In fact, 3 weeks ago, I had two stents put in the left anterior descending,
Descending. Sure.
and then the other one is Ramus.
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 Ramus is a branch. Yes.
Okay, I wasn't sure what that was, but I have my card. I keep it with me.
Good.
And then 2 years ago, when I had a heart attack, they put one in the obtuse marginal.
Sure. That's another branch.
So I have three altogether. Shiny new pieces of hardware.
There you go. So what kind of stent did you end up getting? Is it does it say that? Is it Medtronic, Abbott,
The two new ones are Boston Scientific,
Scientific? Oh, sure.
and then the first one I had put in is Zions
Zions by Abbott.
Vascular.
Abbott Vascular, correct.
Yeah.
So
But-
Zions we don't have Zions anymore, but
Mhm.
the new stents that you got put in by Boston is a newer stent. They're great. All stents. Zions was a great stent too. I've used a lot of Zions. I've used a lot of Boston. These stents do wonderful. I'm sure you're feeling good.
I feel great.
Yeah, this procedure doesn't require general anesthesia. You're able to go up the same day or
Yeah.
sometime the next day. and you should be able to do everything that you were doing previously. You should return back to complete normal life. You should go back to the gym, and you can lead a normal life. No, really limitations. That's the
Yeah,
beauty of stents.
it's a miracle. It's a true miracle. And this time with the 2 stents they just put in, they went in through my wrist,
Right.
this little hole right here.
Sure.
And I had a beautiful looking multicolored
And
tattoo here for a week or
oh,
so.
you did. Oh, I see. There's some seepage. Yeah.
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 But as you can see, it's gone. It's completely
now.
healed. And
Yeah.
I feel fantastic.
So Dan, where are you? Where are you now? Are you in what state?
I'm in Boynton Beach, Florida.
Oh, wow. So
Yeah.
I was pretty close. I used to
Yes.
live in Boynton. In fact, when I first started, I did go to Boynton Hospital. I was in
Bethesda Hospital?
Bethesda. I was in Bethesda for a few 6 months or so before
Yeah.
I moved out and started going to Delray Beach.
Yeah.
So I know that. Did you have the procedure at Boynton Beach or no?
I actually had the first procedure, the heart attack I had at Bethesda East.
Okay. Oh,
Because it's only a mile from here.
Yeah.
And it was an emergency.
Right.
The second procedure I had done at Northwest Medical Center in Coconut Creek.
Okay. I see. Okay.
Because that's where my cardiologist is affiliated.
Oh, I see. Good. Yes.
But actually, Dan, Delray Medical is known now for its extremely good heart physicians.
You're
cardiology,
right. And in fact,
very high. Yeah.
We are so
very happy with
lucky
that.
here in Florida that virtually every major hospital in the area has a specialty heart center.
Yes.
And it's incredible. So virtually any major hospital you go to, they're able to treat.
I definitely miss Florida. I love Florida as a state. I really had a good time. In fact, I was in Florida maybe a couple of months ago, just for pleasure for a weekend. And, I love it. Had a good time, and here we are now in Texas. But I love the Florida weather. I have to tell you, I really like Florida.
Well, maybe your kids will let you come back to
Maybe
Florida.
I'll go. If I retire, I might end up in Florida. There you go.
You might just do that.
We'll put in a good word for you at Bethesda. Let's see, who else do we know? Anita Broward Health. We can get them on board.
Right.
Yeah, there you go. So now I'm reached a point in my life. I've been in practice for 24 some years. If I could get some type of a position where I can help others, some kind of a leadership position, I'd love to come back to Florida and help.
Oh my goodness. Well, hey,
yeah, there you go.
We'll spread the news around.
There you go.
We know a lot of people.
There you go. I appreciate that. Thank you so much.
Thank you. So, Dr. Khan, it's been a great pleasure. I knew you were a lot of fun last time, and you're a lot of fun now. And good luck with your book. And thank you very much for taking the time to be with us.
Thank you, Nita. Thank you, Dan. I appreciate it. Thank you. I enjoyed it.
Okay.
Thank you very much.
It was our
Bye,
pleasure.
everybody.
Take care.
This is a
Bye-bye.
great interview.
Bye-bye.
Take care.